Hi, welcome to What's Happening at Tri-City Medical Center. With us today is Dr. David Cohen, a cardiac electrophysiologist at Tri-City Medical Center, specializes in treating heart rhythm disorders, also known as arrhythmias. Welcome, Dr. Cohen.
Thank you.
Let's start with the question of what characterizes a normal heartbeat.
So that's a good question. It's always good to know what normal is before considering abnormal. Normal heartbeats are a one-to-one activity in the upper and lower chambers of the heart. So the heart has an intrinsic pacemaker called the sinoatrial node. It's in the upper chamber of the atria, and that will be triggered regularly. The rate of that triggering can go up under stress and exercise, and it goes down regularly when you're at rest. When that trigger sends an impulse from the upper chamber to the lower chamber, it hits a central circuit called the AV node, or atrioventricular node, separating the atria and the ventricle. And once that signal is delayed there, it allows blood to flow into the ventricles, and then the dispersion of electricity comes out and squeezes the blood out. So typically a heartbeat will be one-to-one from the sinoatrial node to the AV node to the ventricle. So you get normal sequential contraction of the heart.
We talked about symptoms earlier, and I do want to just get back to one thing. A normal heartbeat isn't noticeable to us.
Yes.
Unless we're under great stress and it's fast. Are all of these irregularities that we're going to talk about noticeable?
Not all of them. So one specific arrhythmia that can be unnoticeable is atrial fibrillation, and we can go into the significance of that, because atrial fibrillation is one of the arrhythmias that increase the risk of stroke. And if it's not diagnosed appropriately or with good time, it can lead to a clot and stroke. So, but I would say the majority of arrhythmias are, people will feel them. So unless they're very brief skipped beats, which we all have, but usually sustained arrhythmias are diagnosed by patient's symptoms.
Okay. And what about treatment? What are the treatment categories? So
there's three categories of treatment for arrhythmias. There's medications or medical therapy. That's typically first line. Medications that will either keep the rhythm in control, medications that will keep the heart rate or the rapidity of the heart under check if the arrhythmia is more chronic or long-term, such as chronic atrial fibrillation. And also the need in some arrhythmias to be anticoagulated or have a blood thinner. So those are the three classes of drugs. Some arrhythmias are amenable to immediate therapies, invasive therapy. Bradyarrhythmias, as we talked about, the slow heartbeats, there's no medications to treat a slow heartbeat, unless, of course, the patient is on a medication that itself is causing the slow heartbeat, and that can be stopped and it resolves. But typically, if there's an irreversible cause for slow heartbeats, then a pacemaker is necessary. And we can go more into detail what that entails. And then in terms of curative procedures for fast heartbeats, there is a procedure called catheter ablation. And catheter ablation is a minimally invasive procedure where we advance catheters that have mapping electrodes, or they have electrodes tips. It's almost like doing an EKG inside of your heart. And we advance these catheters under X-ray and three-dimensional electrical guidance via large IVs in the upper veins in the leg.
Is there always a progression? For example, is there a possibility where the medical therapy is all that's needed?
Yes.
Forever?
Yeah, definitely. Yeah, there is definitely a subset of arrhythmias that can be treated very well with low-dose medical therapy that patients will tolerate. And particularly in patients who are more advanced in age, it's probably more reasonable to consider long-term medical therapy than anything invasive. And that's up to the discretion of the patient and their physician to make that decision. Some medications are necessary lifetime too, such as anticoagulation, depending on your risk of stroke. However, some arrhythmias, especially those that occur in the young, it'd be unreasonable to suggest that they should be on medications for the rest of their life when they can be cured with a catheter ablation procedure, which is something that can be done in the hospital, and they would go home the same day and never experience the arrhythmia again.
You know, I'm going to ask a question that sort of the answer is obvious, but on these shows in general, we like to stress being in touch with your body and knowing it, because obviously treatment becomes, you have more options the earlier it's detected.
Mm-hmm.
What percentage of people do you see who are actually waiting too long? Is that a chronic problem in your specialty or relatively minor?
I think it's relatively minor because most people are tuned in that they come to their primary care physician with these symptoms. Their doctors are well trained to make the correct diagnosis, refer them to the appropriate specialist. I think it's more of an issue I've seen in patients that are underserved, and they'll come to you in the later stages. But it's still fortunate that the tools we have can still provide these patients with a good outcome.
All right, well, let's talk about device therapy then. There's two big categories.
Sure. So device therapy involves pacemakers and defibrillators. And the difference between a pacemaker and defibrillator is that a pacemaker treats the slow heartbeats. So the integral aspect of both these devices is the same. It involves a small generator that's implanted underneath the skin on the chest, and then leads that are fed within the vein under the clavicle into the upper and lower chamber of the heart. A pacemaker treats slow heartbeats. So if the heartbeat is too slow, the pacemaker will detect that and send an impulse to the upper and lower chamber of the heart and synchronize the heart back at a normal heart rate. A defibrillator acts just like a pacemaker in the sense that it has pacing function, like I just described, but it's also used to treat very dangerous fast arrhythmias, those malignant arrhythmias in the bottom of the heart, ventricular arrhythmias such as ventricular tachycardia and fibrillation. So the lead in the bottom of the heart will detect those fast arrhythmias, and it will either try to rapidly pace into the circuit, which is a painless a way to break it, or will send a jolt, which is not pleasant, but it's better than the alternative, which is death.
That's definitely preferable.
Yeah. And the pacing is, patients don't feel it. It's just like having your normal heartbeat. But defibrillation with the shock you will feel. The procedure itself is outpatient in the sense that patients will go home the same day. Very minimal downtime. They are back to their normal activity. It's just a matter of not lifting up the arm where the site was implanted so the leads don't get pulled back. But in terms of returning to your normal quality of life, it's within days, and usually this is an improvement in the quality of their life, especially if they were suffering with very slow heartbeats and the associated symptoms, or they're at risk for sudden death, and now they have that very important insurance policy.
Is this always a lifetime decision for either a pacemaker or defibrillator?
Yeah, they're both called permanent. So these are devices that stay in. Very rarely they can be taken out, but preferably that should be maintained there for the life of the patient.
Dr. Cohen, thanks for great information. I know we've done some good today.
Thank you.
And thank you for watching. If you want further information on electrophysiology at Tri-City Medical Center, please visit tricitymed.org. Thanks for joining us on another episode of What's Happening at Tri-City Medical Center. To watch this or previous episodes, visit our video on demand page at KOCT.org. We'll see you next time.